All right. I'll just take this from you. I've got to get the speaker. That's a good idea to stick that in. Okay, well, we're going to keep you in suspense a little longer then. I can just safely say that everything I know I learned from Abe Rudolph. Which I didn't learn everything he taught me, though, that unfortunately. So I'm still lucky enough to be able to listen to him and hear what he has to say. So now I have to find my talk on Ebsteins. Here it is. Okay. So I've allotted myself 25 minutes, which is going to be somewhat of a feat. And, you know, Wilhelm Epstein was a German. He lived in Berlin and Breslau and became the professor of medicine in Göttingen. He, in the last century, when he became a physician, he had authored over 300 papers in the era where publish and perish didn't mean anything. And he has 3 eponymous diseases attached to his name. Obviously, the one that we know. There's an Epstein kidney, which is associated with diabetes. And then there's also the phenomenon known as the Pell-Epstein phenomenon, which is an afternoon fever associated with leukemia or lymphoma. So he was a pretty smart guy. He was well trained. He was trained in pathology. He was a sort of a Renaissance man. He trained in pathology with Rudolf Virchow, who you're also familiar with. And a 19-year-old bricklayer came into his ward with a cyanosis and faint feeling, and he was put in the ward. He had a irregular heartbeat, and he died. And his name was Joseph Presser, and Epstein, being a well-trained pathologist, did the autopsy on him, and in these days there was no Kodak moments. So what they did is he called an etcher, a man that does etchings, and he etched these pictures of Joseph Presser's heart. And they still stand today to be one of the most exquisite examples of pathology, because this shows the whole morphology of the Ebstein's malformation. We're looking at the right atrium and the atrialized part of the right ventricle here. You see the fossa ovalis. You see the pectinate muscles of the right atrium, the enlarged right atrium, the coronary sinus here. You see the, very nicely emphasized here, the atrioventricular junction. The septal leaflet is vestigial and hyperplastic. The anterior leaflet is large. There's some fusion, abnormal papillary musculature here, and a displacement downward of the spiral of the, this is the posterior leaflet, this is the anterior leaflet, sorry, of the annulus of the valve. And when you turned the heart over and looked at the right ventricle from the outflow tract, you saw the characteristic, here's the pulmonary artery, here's the Y of septal band over here, here's the papillary muscle of the conus, and here's the valve of a keyhole orifice within the abnormal anterior valve with fusion of the anterior leaflet with the mural leaflet and this vestigial septal leaflet seen through the hole. Now, I have a cartoon here of which I made myself from Netter's book, showing the tricuspid valve with its 3 leaflets and the papillary muscles in the normal position. And I have a patient, this is my Joseph Presser, who was about 9 years old when he had his atrial septal defect closed, and unfortunately after the procedure he died. And you can see here I have drawn in orange the position of the atrioventricular junction. And I have as well in blue indicated the area where the valve is attached to the annulus or attached to the wall. And you can see here that the valve is progressively displaced from the annulus of the valve and is attached within the ventricle, giving rise to an atrium an atrialized right ventricle, and on the other side of this, the true right ventricle. Note also the abnormal nature of the valve, the lack of tendinous cords, and the abnormal caudal attachment that is seen here. So I like to think of Ebsteins as the dozen Ds, and I'll be happy if you can tell me any more Ds. So there's displacement of the proximal attachment of the valve. There's dysplasia of the valve. We've seen that. The distal attachment is abnormal. We've seen that. There's dysplasia of the underlying myocardium, which we haven't really seen yet. And of course, when you're looking at an echocardiogram, there's tricuspid regurgitation. But as you know, there's no D in tricuspid regurgitation. So I put it as Doppler evidence of tricuspid regurgitation. And the rhythms are abnormal, so I call them dysrhythmias. There's dilation of the right heart chambers, which we've seen. There's diastolic dysfunction abnormalities and alliteration, indeed. The ductus arteriosus provides a lot of problems in understanding this disease. There's deformity of the right ventricular outflow tract and pulmonary valve, and there are other defects. And the last D, death. I guess it's the same for all of us. So it's not so unusual, but it's just that it's somewhat hastened in Ebstein's malformation. Now, the essence of the malformation is a rotational displacement of the atrioventricular junction. And that is the most important concept in terms of understanding the morphology. The right ventricle becomes atrialized because the valve is displaced. And the displacement occurs in a spiral, so based on the anterior leaflet. So if this is the annulus of the valve and the tricuspid valve in us, the right atrioventricular junction is sitting as a circle here. But in Ebstein's disease, it's rotated in this direction. And the rotation depends on the severity of the disease. So you see it's hinged on the anterior leaflet and it rotates upwards and downwards, okay? And it's maximal at, as I showed you on the specimen, at the junction between the septal and the mural leaflets. And because of that, when you look at tricuspid regurgitation, if in a normal valve, regurgitation goes through the valve, as the pen is, the regurgitation goes away from the anterior chest wall. But when the valve is rotated down this way, the regurgitant jet goes down towards the diaphragm. And it's one of the few conditions where tricuspid regurgitation, when it occurs in that area. Now, this is a picture from Frank Netter's book, which was done actually by Bob van Meerop, who is a cardiologist, a cardiac surgeon, a morphologist, and a herpetologist. A herpetologist is somebody who understands snakes. If you ever visited Bob van Meerop, you would have dinner with him and his python. But anyway, here is an angiogram showing the so-called inverted 3 sign, showing the area of the AV junction and the area of the attachment of the valve, making this border here. And when you dissect the heart, you can see the same thing here. And here is the displacement of the valve from its annular area here, normally, into this area here. And so if you look at the plane of the valve or jet regurgitation, it occurs in that direction. Now, where does Ebstein's begin? I'm sorry to encroach on your area, Dr. Rudolph, but you taught me well. So this is a 19-week fetus that we examined that had Ebstein's malformation. Okay, the mother of this fetus actually had been taking lithium, had a depression because of a leukomalacia. She had good reason for the depression. But you see the fetus has a 4-chamber view echo here. The tricuspid valve is displaced. There's tricuspid regurgitation here, even at 19 weeks of gestation, massive enlargement of the atrium, and this is just the right ventricle over here, which we can see some displacement on. When we turn over this fetus and look at the area of the ductus, here is the diaphragm, here's the fetus's neck, here's the chest wall, here's the spine. So we have front, back, top, bottom and top here. And you can see here's the tricuspid regurgitant jet. And here's the aortic arch in blue. And then here you see the ductus here in red, so that there is already at 19 weeks in this fetus a left to right ductus shunt. Okay? And if you didn't like this picture, we can do a Girish John Simpson cut. We put a little arrow down over here and we turn it around, and then we get a 90-degree axis here. And here you see the descending aorta, the pulmonary valve, the tricuspid regurgitation, the large right ventricle. And you can see here's the descending aorta and the right pulmonary artery. And the ductus is already shunting left to right in this 19-week fetus. Okay? And so here I have a specimen of a 38-week fetus with Ebsteins malformation. Look, here's this abnormal septal leaflet. Here's the anterior leaflet. There's the muscle of Lancisi or papillary muscle of the conus. Here's the anterior leaflet, and here's the mural leaflet. And you can see this verrucous vestigial nature of the valve leaflet, but we're not actually interested in that area. We're interested in this area where there's a probe that is placed in the pulmonary artery and is indenting the pulmonary valve, which has become fused in the course of gestation. Here is the gestational 20 weeks of fetal life, and you can see here that the valve is moving beautifully, but that at 38 weeks, just before this baby died in utero, there is actually no movement here. And that tells you what's happening physiologically, because with the tricuspid regurgitation, there's ineffective propulsion of blood flow up the right ventricular outflow tract, okay? And because the ductus is at systemic pressure, it's holding the pulmonary valve closed, and the pulmonary valve just simply grows together as a plate. And that, I think, is one of the critical features of Ebsteins in the fetus. Now, here's a patient that had an Ebsteins malformation. We've sliced the heart in a 4-chamber view here. You can see the anterior leaflet. You don't see the posterior leaflet of the valve, in fact, because it's plastered down. And maybe this is just the little free edge of the valve. And here's the septal leaflet, which is somewhat displaced from the mitral leaflet at this area here. And so this is atrialized right ventricle. I beg your pardon, this is atrialized right ventricle. This is true and enlarged right atrium. Here's the tiny left atrium, the left ventricle. And this is the true functional right ventricle. And what we did in 1989 was we planimeted the area of the right atrium against the rest of the heart. And this became known actually as the Sellermeyer index and not the Robeson-Silverman index, as you see from the original paper here. The only thing I've managed to get my name eponymized on is a lethal condition. So let's look here at some of the other issues that occur in Ebstein's disease. And probably, if you understand the etiology of the valve abnormality, it's due to the fact that the valve does not develop the apoptosis and delaminization so that it migrates from its caudal direction up to the region of the AV junction. And here is a 18-week 18-stage, Streeter stage, about a 45-day fetal embryo. The cushions have fused. The atrial septum is here. Here's the Eustachian valve. Here's the pulmonary vein. And look at the spongy nature of the myocardium in the fetus. And as you know, about 15% of Ebstein's malformations have spongy myocardium. So here in the fetus is evidence of the spongy myocardium. You don't see a tricuspid valve because in the 4-chamber view as a posterior view, the tricuspid valve is rotated so anteriorly that it's not even seen. And this fetus had terrible left ventricular function in addition to severe Ebstein's malformation, and so underwent a heart transplant at 2 days of age. And you'll see here the postnatal example of left ventricular function in this very child, which was very poor, but you can see in addition that there is an association of spongy myocardium with Ebstein's disease, which occurs in 15% of Ebstein's disease. So dysplasia, as we mentioned, is certainly a feature, and that's what happens. Well, I've shown you 4-chamber imaging, and we don't have a lot of time, and I want to get to this here, because here is a typical example of Ebstein's disease, and you can see a lot of tricuspid regurgitation. You can hardly see any tricuspid valve, and the reason, as I said, is because the valve is displaced forward into the outflow tract. So when you do a standard 4-chamber view, you don't see very much of the valve at the back. So that's an example of Ebstein's, and here is what I think the secret of Ebstein's disease is. In the normal heart, you have a beautiful Eustachian valve. This is a subcostal sagittal image with front, back, top, and bottom. And the septal leaflet, I beg your pardon, the mural leaflet, the inferior leaflet, not the septal leaflet, which I think is the most important leaflet in Ebstein's malformation, because it's the most displaced and the most abnormal, is situated at the back of the heart, and it is normally very close to the Eustachian valve. But in Ebstein's disease, it is rotated around in a distal direction. And so we can look at that, and we can see that even in the fetus. And this is a conceptual picture by Christian Schreiber of the position of the normal atrioventricular junction and the various patients with Ebstein's malformation going from the mildest to the most severe displacement of the valve. And here are some echocardiograms showing you a fairly moderate degree of displacement. The valve is coapting up here. The jet is coming towards the diaphragmatic surface of the ventricle, and therefore it is prograde in its direction. And this is at orthogonal planes to this. So here's the pulmonary valve. Here's the left ventricular outflow tract. Here's the anterior chest wall, and the tricuspid valve is displaced up close to the pulmonary valve, and this is all that there is in this patient of a functional right ventricle. Okay? So we've talked about the jet direction, and I can emphasize this again and again. It won't make any difference. Sometimes the tricuspid regurgitation is very, very severe in this condition, and I think is one of the overriding physiological considerations and driving of what all of the other abnormalities in Ebstein's disease are. There's so much tricuspid regurgitation that it's refluxing into the coronary sinus and making the coronary sinus very large. When you see this in the fetus sometimes, or in the neonate, this is a neonate, there is not only is there dysplasia of the valve, but because the chordae tendineae are also abnormal in the condition, it doesn't allow adequate coaptation of the valve. And you can see here that this valve is pitifully insufficient. And these patients do very poorly. Now, in terms of Ebstein's, we just have to stop for 1 minute here, because there are, all Ebstein's were once upon a time fetuses. But the clinical presentation at birth is often that of a profound cyanosis with a condition like this, with massive tricuspid regurgitation, where there's not a whole lot you can do for the right ventricle. And then there's other clinical presentation where, as the ductus arteriosus closes and the pressure in the right ventricle drops, there's then prograde flow, and the heart shrinks down in size quite dramatically. And those patients I would call the adult type of Ebstein's malformation, and this I would call the fetal type. So there are clearly two different kinds of Ebstein's disease. And this is just for you, Karen, to show that there are cases where MRI is useful, and you can talk about that in greater detail. Now, not all Ebstein's is as simple as it appears. Here's a patient who doesn't seem to have a lot of a lot of displacement, and has done very well as an adult-sized patient. And you can see the tricuspid valve is not opening and closing here, but there is flow, and there's not any tricuspid regurgitation here. Okay? And indeed, this is actually a patient with the most extreme form of Ebstein's, where the tricuspid valve is plastered against the right ventricle. And the only reason this patient is alive is he was lucky enough to have a ventricular septal defect, which you can see over here. And this was a restrictive ventricular septal defect. So he had a left to right shunt from the VSD into the real functional right ventricle and up the pulmonary artery. So just to show you that even in the worst kind of patients, there's still some hope for survival. Okay. Now, the adult type of Ebstein's disease is this kind over here, and you can see the functional right ventricle, the moderator band, and the verrucous nature and curled nature of the abnormal tricuspid valve. Now, my adult colleagues only know one form of tricuspid regurgitation that's congenital, It's called Ebsteins malformation. It's not really always. Some patients have asymmetrically short tendinous cords, have big dilated ventricles, and if you can do an annuloplasty on this non-displaced valve, you can take care of the tricuspid regurgitation. Now, because this may be a developing and acquired condition, there's very frequently not an atrial communication. There's almost always an atrial communication in Ebsteins malformation. So what are the goals of surgery? The goals of surgery are to diminish the tricuspid regurg, remove right-sided outflow tract obstruction, maximize cardiac output, minimize right-side congestive failure, and obviously decrease arrhythmias even by doing a maze procedure, which is disconnecting the atrium and making fibrous tissue between the atrium and the ventricle to prevent atrioventricular disease, and obviously close shunts if you have to. Now, Carpentier made this classification of Ebstein's disease, which I think is pretty much what we see on echocardiogram. He described an operation where he cut the tendinous cords after removing the tricuspid valve, rotated it round, did an annuloplasty, and put in a ring. Unfortunately, this can only be done in older patients. Now, Dr. De Silva, Pedro De Silva, has talked about making this a cone procedure. And what he does is essentially similar to the Carpentier procedure. He disconnects the valve, does an annuloplasty, controls the valve, even uses pericardium to augment the septal leaflet, makes an annulus and puts it round in the same direction here. He's closed done an atrial reduction in this region and put the valve back in its true annulus. It's called the cone procedure. It's called the cone procedure because you disconnect the valve, turn it into a cone, and move it from its attachment over here to an attachment over there. And here's an example of how it's done. And indeed, here is the pericardial patch, which augments the septal leaflet and creates the rest of the cone. And this procedure has certainly revived interest in Ebstein's malformation across the ages. And here is the final step where you have a functional valve at the time of surgical closure. Now, I think that the fetal procedure doesn't do very well. The fetal type doesn't do very well, and sometimes you have to just exclude the right ventricle. That's called the Stans procedure, and what that is essentially a patch that is placed over the valve, and a little hole is placed in it to allow the blood to escape out of the ventricle so it doesn't do very poorly. And of course, there was an 80% survival of this case published in the journal. It was popularized at Stanford, and so there were no mortality except that this is something that we find now that obviously, even though in the best of hands it's a great operation, it does have a mortality to it. Now, I'm not going to talk too much about transesophageal echo because I think that essentially it repeats the procedure. The popularized in the Mayo Clinic is, in fact, in some adult patients, it may be better to put in a bioprosthetic valve, as you see here. Problem with bioprosthetic valves is they tend to degenerate, develop thickening of their cusps so that they become stenotic and insufficient. The patient goes back into right heart failure. Ebstein's malformation, as Dr. Sanders showed us yesterday, also occurs in corrected transposition. The only difference between Ebstein's in corrected transposition is that it's really functional mitral insufficiency because that's the systemic ventricle. So it's quite a lot more serious, and I think that the cone procedure or any other prosthetic procedures on this type of valve are not very successful. Okay? So I think that's more or less what I have to say on Ebstein's malformation here. And let me just finish off with something that's not Ebstein's malformation. So not everything that has tricuspid regurg is Ebstein's disease. Look here, there is no displacement of the septal leaflet from the mitral valve anterior leaflet. And if you don't like that picture, I can show you the others. And you can see that there's tricuspid regurgitation. And these patients are very successfully handled with a valvuloplasty. Here's an adult patient, massive atrial enlargement, and tricuspid regurgitation, which was well handled by means of an annuloplasty. So because football season's here and I'm a fan, I have a picture of football posts, and thank you for your attention. Oh, this is for Dr. Rudolph now. And now you're going to hear the real truth.
Thanks. Yeah. Well, as Dr. Silverman has already pointed out, this disease is an extremely variable, has an extremely variable presentation. Now, my task that has been assigned to me today is to discuss the neonatal and fetal periods. But I want you to understand that the severity and the presentation of Ebstein's malformation is extremely variable. And although what we're talking about is in the fetus and newborn is the most severe form, it's far more common for Ebstein's not to be so severe and to present later in life. And in fact, before we used to have the advantage of doing echo, it was not at all unusual to find that patients who had been diagnosed as having small ASDs turned out to have Ebstein's malformation when they were studied. And the reason is that if the tricuspid valve insufficiency is not too severe, which is what is true in these patients who have mild degrees of displacement of the annular region, that in these patients, they may have some mild tricuspid insufficiency. As Dr. Silverman mentioned, they very commonly have an atrial communication, a foramen or an atrial septal defect. And so that if there's mild tricuspid insufficiency, these patients may present just with the ASD shunt, and that's why they're diagnosed as having small ASDs. So that I just want you to understand that although what we're going to talk about today sounds horrendous, that this is not the classic presentation of Ebstein's malformation, that it has this enormous range of severity. Now, when you think about the factors that influence the manifestations of Ebstein's malformation, they are the severity of tricuspid regurgitation, the size of the functional right ventricle, the degree of pulmonary stenosis, we'll talk about that more, the presence of pulmonary insufficiency, the magnitude of the left ventricular output, the size of the foramen ovale, development of the pulmonary circulation, and of course arrhythmia. So that what you see is that there are so many different factors involved in determining how these patients are going to present. Now, in the fetus, as I said, because of this variability, if there's mild to moderate tricuspid regurgitation, you probably won't even recognize that as an issue, and most of these fetuses go on to survive and do perfectly well. When we recognize the disease in fetuses, it's usually the severe form. So that if we recognize, if a patient is diagnosed during fetal or neonatal period as having Ebstein's malformation, the mortality in those patients is very high. the reported mortality is something like about 50%. And that's because these are the worst patients who have the most severe form of the disease. I'm sure as we do more and more fetal echo, we'll begin to diagnose these milder forms, but at the moment, the majority that are diagnosed are severe. Now, the fetuses with a severe regurgitation and or a functionally small right ventricle are unable to provide forward flow through the pulmonary valve. Now, as you saw in those one of the last pictures that Dr. Silverman showed, the degree of displacement of valve varies tremendously. And there are two factors that determine what the output of the right ventricle is going to be. The one is the degree of tricuspid regurgitation, but the other that's very important is the degree of functional right ventricle. So if the tricuspid valve is markedly displaced from the annulus, the functional right ventricle is very small. So that even though there may not be severe tricuspid regurgitation, this ventricle is not able to provide a reasonably good output. Now, when the ventricle does not provide an output for either of these two reasons, remember that in the fetus, there's a communication between the pulmonary artery and the aorta, which is the ductus, and that pressure from the aorta, which is high, is transmitted through the ductus, and therefore, with a high pressure in the pulmonary artery, the right ventricle cannot develop a pressure adequate to open the pulmonary valve. So that this is an interesting situation where you get functional pulmonary stenosis or atresia if the valve is completely closed. So this is a functional closure of the pulmonary valve. But it's important because it means that there's no right ventricular output into the pulmonary artery. And this becomes terribly important when we get to the period of birth, which we'll discuss in some detail in a moment. Now, the other important thing that isn't stressed enough in Ebstein's malformation is that because of especially when there's severe tricuspid regurgitation, the right atrium and the functional right ventricle become massively enlarged. You saw the one picture that Dr. Silverman showed. This enlargement of the heart has a tremendous impact on the left ventricle, so that this massive right ventricle imposes a restriction to filling of the left ventricle. And because of that, left ventricular output is decreased. Now you can imagine what an impact this has, because if the left ventricular output is reduced and there's no right ventricular output, the only blood going to the body is from the left ventricle, and if that output is reduced, the total blood supply to the body is reduced. This means that one of the crucial flows in the fetus to the umbilical circulation, umbilical placental circulation, is going to be markedly reduced. And that's why these fetuses and newborns who have severe Ebstein's malformation in utero are poorly developed. They restricted in growth dramatically because they just have inadequate placental circulation. Now, the other thing that this does is that because of the fact that there is this enormous regurgitation and elevation of right ventricular pressure, remember that hydrops fetalis in the fetus, edema of the fetus, you can equate that with elevated venous pressure. It's always associated with elevated venous pressure. And because of the fact that the right atrium gets this enormous regurgitation, right atrial pressure and venous pressure is markedly elevated, and it's not uncommon for these fetuses to develop hydrops and die with severe right-sided failure, essentially. The other important thing that is not stressed enough is that this marked enlargement of the heart compresses the lung development, and therefore many of these babies who are born with these huge hearts are very difficult to resuscitate after birth because they have small lungs, and it's one of the major problems. And many of them die because they cannot even be resuscitated because you cannot get them ventilated adequately. So, again, I just wanted to stress, though, that this is not the usual presentation, it's one of the presentations. Now, it's really interesting when you think about this condition that pediatric cardiologists spend an enormous amount of time on newborns with Ebstein's malformation. And the reason is that they are so complex. There's so many difficult issues that have to be considered, and that's because of the extreme variability with which they may present, as I mentioned. Now, one of the things we don't know is what happens to fetal circulation. We don't know what the venous return patterns are like in the fetus with Ebstein's, but I can predict, I may be wrong in my prediction, but I can predict that because of this tricuspid regurgitation there and the enormous turbulence that occurs in the right atrium, that there almost certainly is disruption of the selective streaming pattern of ductus venosus and left hepatic venous blood towards the foramen and into the left atrium. And probably there's more or less complete admixture within the right atrium, which would mean that the normal separation of saturations going to the upper and lower body are probably not present. And that the blood that goes to the different parts of the body all has the same saturation in the fetus. Now, I mentioned that if the right ventricle is able to generate pressure to provide forward flow, pulmonary stenosis will not ensue. But we do have another interesting presentation in these patients, fetuses with Ebstein's, and that is pulmonary insufficiency. Now the question is, how does pulmonary insufficiency develop? Well, I don't know exactly what the mechanism is, but from looking at pictures of fetal hearts in which there is pulmonary insufficiency, I think the reason is that the outflow tract of the ventricle in these fetuses is very enlarged, and I think it's a functional thing created by the enlargement of the right ventricle. So that I think this too, as is the pulmonary stenosis, which is a development that occurs in these things. I think that this is also not a normal phenomenon, but is secondary to the enlargement of the right ventricular outflow tract. But the important point about this is that it has been noted that this is a very drastic physiological problem, because you can imagine what happens. Let's go to the next slide. If you have a situation where there's a ductus arteriosus present and there is a pulmonary valve which is insufficient, this means that you're going to exaggerate the tricuspid insufficiency. Because what happens is you have blood coming from the high pressure aorta into the pulmonary artery, and then with pulmonary insufficiency, this is going to, and tricuspid insufficiency, you're just going to have a massive shunt, which has been called a circulatory shunt, because the blood just goes from the aorta through the ductus into pulmonary artery, right ventricle, right atrium, across the foramen into left atrium, left ventricle, aorta, and then it just keeps on shunting. So this is a very bad situation in terms of functional aspects of the circulation, because this means, of course, that you get very little blood going to the body. It's all just circulating around and around in the heart. Now, it has been suggested that the problem here is that there's a shunt from the high pressure aorta to the lower pressure pulmonary artery and right side. So it has been suggested that maybe if you close the ductus, you can help these babies, these fetuses. And Dr. Turetsky in Boston has actually tried this in a few fetuses. He's given indomethacin to the mother to close the ductus in the fetus, because indomethacin does close the ductus when non-steroidal anti-inflammatory agents are given to the mother. They pass through the placenta and do affect the fetal ductus. So he's given this and has noted, this is very preliminary work he's done, he's noticed considerable improvement in some of these fetuses. Now, I think it's interesting from the point of view of experimentation. I would imagine, though, that these fetuses are not going to eventually do very well anyhow, because they have very severe forms of Ebsteins malformation. But it's a very interesting issue. Now, when you talk about what happens at birth, again, the presentation at birth is extremely variable depending on which of these factors that I've mentioned are involved in the baby. So we have the situation then, if we have a baby with severe tricuspid insufficiency, an open pulmonary valve, and a closed ductus. This is possibly the best type of presentation that you could hope for in a baby born with Ebstein's. And so that in the early postnatal period, the main concern is establishment of an adequate pulmonary circulation. Obviously, you need that. Now, one of the problems I mentioned is that you may not be able to get these babies to breathe properly. So that's the first real problem, is to get them ventilated properly. But while pulmonary vascular resistance is still elevated, the pulmonary blood flow will be low, and because of the fact that there is this high outflow resistance in the pulmonary circulation while pulmonary vascular resistance is still high, tricuspid regurgitation will be severe. So that these babies present with significant tricuspid regurgitation, and because of the tricuspid regurgitation, right atrial pressure is high, so they have a right to left shunt through the foramen, so they're pretty cyanotic. Now, if you can get them to breathe well and you can drop their pulmonary vascular resistance, what happens? Well, it has a tremendous benefit, because by reducing outflow resistance on the right ventricle, you reduce the amount of tricuspid regurgitation, thereby reduce the right to left shunt because of the reduction in right atrial pressure. And these babies may go on to do perfectly well for a while after birth. So that's what your objective then is to try to reduce pulmonary vascular resistance. Now, because the reduction in pulmonary vascular resistance is so important, if you can't do it by just ventilating the baby, then other things should be tried, like oxygenation and pulmonary vasodilators, so that the use of nitric oxide and sildenafil is very strongly advised when you're having trouble with trying to get a baby to ventilate, with Ebstein's malformation, to ventilate and to develop adequate pulmonary vasodilation. Now, the question is, what happens if you can't improve oxygenation? And in order to maintain pulmonary blood flow, you may have to give prostaglandin. So you really have, or subsequently, to provide a pulmonary shunt, an aortic pulmonary shunt. So you see that this, as I'm talking about it, is the best situation you can expect in these babies. Now, what about other situations? So now if we have a situation of a baby with born with Ebsteins who has severe TI and who has pulmonary regurgitation and a patent ductus. So this is the extension of the fetal problem now into the newborn period. So how are you going to cope with this? This is the baby who has the circulatory shunt. What are you going to do? Well, these babies usually have severe cardiac failure during fetal life. This present postnatally, hypoxemia is present, may not be severe because pulmonary flow in these babies is maintained through the ductus, blood flow through the ductus. So it's a difficult issue to decide what you want to do. Closure of the ductus would seem to be indicated to improve the tricuspid regurgitation. However, if you close the ductus, the baby may not have adequate pulmonary circulation. So how are you going to do this? It's a real quandary. You can close the ductus in the newborn by giving indomethacin. We know that. So should you give indomethacin or shouldn't you? Well, if you give indomethacin, there's the risk that you may close the ductus and stop pulmonary circulation, and the baby will die because they have no pulmonary circulation. So what my recommendation is that you do, and we've had a couple of experiences with this now in our nursery, is what you do is you give indomethacin, but be ready, be prepared immediately should there be a problem to give prostaglandin infusion. Now, you may ask, well, does prostaglandin help if you close the ductus with indomethacin? And I assure you that it does. We have shown in fetal lambs that if we close the ductus with a non-steroidal anti-inflammatory agent, that the ductus is still very responsive to infused prostaglandin. Because what the indomethacin does is it stops production of prostaglandin. It doesn't stop the effect of prostaglandin. It stops the manufacture of prostaglandin by the tissues, by the endothelial cells. So that the ductus is still responsive to prostaglandin. And then you can once you've done that, you can then decide what you're going to do, whether you're going to continue giving the prostaglandin or whether you're going to introduce a shunt, which will be manageable in terms of providing pulmonary blood flow. So that what I really want to present to you is the fact that in the fetal and neonatal period, when you diagnose Ebstein's, it's usually a difficult problem you're going to have to deal with, and you should be prepared to deal with all these eventualities. Thank you.
And I think that we have to acknowledge that the work that Lisa Hornberger and Ian Astia have done in terms of using ventilation, nitric oxide, and closing the ductus in terms of, and a surprising number of these patients actually do very well. You know, I showed that one patient that I had from our own collection of pathology that showed the pulmonary atresia, but I think that, you know, some of the development of the pulmonary valve relates to forward flow across the valve. And when you have the ductus shunting at high levels of pressure into the pulmonary artery, it might distort the pulmonary valve leaflets, and so they actually are a little distorted as well. And some of the pulmonary insufficiency is, I think, based on a deformation of the valve leaflets rather than, you know, just the fact that the infundibulum is enlarged. But it's certainly a big problem, and I think fetally we look at that. I think that the biggest issue is to be able to say which of the two areas you're going to be involved in when the baby's born. Are you going to have a fetus or a neonate that is going to be a problem respiratory-wise and physiological-wise, or is it going to be that baby with the natural history? And you showed me this many, many years ago when we closed a ductus arteriosus in an Ebsteins disease, and the heart size moved from almost 80% to about 65%.
The one point I want to stress is in those who have an open ductus, it's really very important to recognize that you may need to have that ductus to provide common blood. Although it's not good from the point of view of tricuspid good, these babies may not survive if you close the ductus. And we had an episode very recently in our institution where we had a baby with exactly that situation, a circular shock, and where it was decided, for some reason, I don't know why, to close the ductus with a procedure device. Now, that doesn't give you the option. Once you close it, it's closed, you can't eliminate it. And that's why I stress that you have to recognize you may need that ductus. And this baby guy, you may need that ductus. And that's why I'm recommending what you do is rather use chemical means of closing the ductus than you do the bedside, because you can overcome that by giving prostaglandins.
Sure, and I think there's just one other point about management that I've learned from you, and that's that you have to be constantly vigilant in these patients. These aren't the kind of patients you can write an order in the chart and disappear out of the hospital and play golf or something like that and come back and expect to see the patient is doing well. These patients require your constant attention, and they require also that you don't make rapid changes unless you really need to, because the whole circulation is so fragile that when you start to do things very quickly in these patients, they do particularly poorly. Thank you very much, Abe.
One of the things I wanted to mention with 2D and a Doppler was, you know, we had a baby with Ebsteins who had a pulmonary valve that just wouldn't move postnatally, you know, and so there was this question of, is this pulmonary atresia or what's up with that? And but what we saw was just a tiny bit of regurgitation through this supposedly atretic valve. There was no prograde flow because there was so much tricuspid regurgitation that the right ventricle was just pressure deconditioned. It wasn't going to be able to open the valve. And so I actually wondered whether this concept of, say, in systole itself, when the ventricle contracts, although it may not be contracting at a pressure that's adequate to open the pulmonary valve, so it's lower than PA diastolic pressure, but it's just enough to distort those leaflets during that time to allow the valve to leak. In any case, that sort of gave away the diagnosis that this was not an atretic valve, and we started nitric and indomethacin, and sure enough, within certainly with the nitric, within about 15 or 20 minutes, we had pulse wave evidence of forward flow. Just enough to prove that it was not atretic.
I mean, there's one other analogous situation, and that's what happens in the patients that have pulmonary atresia that get a perforation of the valve. Those patients, you have exactly the same dilemma about what you do about closing the ductus. And, the interventionists scream about trying to close the ductus because they think the valve is patent and it opens. By the way, that point that you mentioned about pulmonary insufficiency was described by Bill Berman and Paul Stanger in pulmonary atresia by angiography, I think in the 70s, where what they did was they did an injection in the descending aorta, saw the left to right shunt, and looked to see that there was actually pulmonary valve patency. So, I mean, color Doppler has made it much easier for us, but it's been a phenomenon that's been known for a long time.
Yeah, it's first seen it in Bob Freedom's book, actually, of angiography. Yeah. Okay, so much of the discussion of Ebstein's malformation really is going to focus on ventricular function and all of that. So this is where I think Mark is really going to be coming in. I'm just going to show you a few pictures of morphology, which is where 3D can really help out. So this is a parasternal long axis view, and the reason that you don't see the left ventricle well here is because the left ventricle is squashed by this right ventricle. This is a unusual and sort of it's just one part of the spectrum of this malformation. This is a part of the spectrum where the right ventricle is actually quite is of good size. And what you're seeing here is the septal leaflet and the anterior leaflet of the tricuspid valve. So it's a parasternal long axis view that's tilted slightly towards the inflow. And if you want to look at the way that these leaflets really look, you can kind of look at them from the right side. So this is sort of a picture that is probably analogous to the picture that Dr. Silverman showed from Dr. Ebstein's original description. This being the septal leaflet over here, this little thing over here is a septal leaflet, you see? This little piece here, that. And all of the rest of it is an anterior leaflet. Many times with Ebstein's, the tricuspid valve is not really a tri-leaflet tricuspid valve. So the septal and the inferior leaflets can be fused, and it can be a bicuspid tricuspid valve, if you will. Or, and so here you just have a bicuspid valve with this and that's a pretty useless piece of stuff there, this septal leaflet. I've not found the apical displacement part to be particularly all that of the septal leaflet to be all that useful when you barely have a septal leaflet. It's sort of, to me, it doesn't really seem like a big part of what the problem is with the entity anyway. This is a full volume, and I think all it really shows you is where the mitral valve is, where the IVC is, where the anatomic annulus is. This is the back wall of the atrialized part of the right ventricle. So all of this is atrialized right ventricle. The tricuspid valve opens like this. And if you tilt this, you get a really good sense of that line there. You see that line over here? So this line over here is where the tricuspid valve should have been inserting. So from here to there is all atrialized right ventricle. This is the posterior wall. And then the other thing that I'm going to do now is just to show you the abnormal angulation of the opening of the tricuspid valve. So now we're looking from behind forwards, and as I give this back over here, you're going to see the opening of the tricuspid valve, which is more anterior and into the outflow. So this is septal leaflet, that's sort of anterior leaflet there, and this is that almost keyhole or triangular shaped orifice of the tricuspid valve opening out, not to the apex. Okay. I have a couple of other pictures to show you. These are not Ebstein's, but they are just examples of ugly tricuspid valves that I thought would belong in this part of the presentation rather than any others. So straightforward parasternal long axis view, but the right side looks kind of big over here. And I'm going to take a quick look now at what this looks like from the right side. So this is actually a kid who had a heart transplant and had increasing tricuspid regurg, and our best guess is that the bioptome that was used for biopsies probably took away some part of the tricuspid valve septal leaflet and its cords. So this is an en face view of the tricuspid valve in this lesion. And what we are seeing here is the septal leaflet, the anterior leaflet, and a pretty large posterior leaflet. And once again, the concept from yesterday that you have 3 commissures, 1, 2, and 3. So this one here is the anteroseptal commissure or lack of commissure. This is septal leaflet, this is the septal inferior commissure, and that's the anterior inferior commissure there. So you can see this huge area of non-coaptation of the valve leaflets. And looking at it from the ventricle, once again you get this sense of, there's nothing flail or anything like that, but it's just a very unfortunate situation with this tricuspid valve. And then the other one I wanted to show you was this young man had tricuspid valve that somebody threw a pumpkin at him, and he didn't catch it. It fell on it, landed on his chest, and it ruptured his tricuspid valve papillary muscle. So this is his papillary muscle over there. We've become a very violent society, as you know, in the United States, but people don't even need guns anymore. They can do damage with pumpkins. So, anyway, so that's his, looking from behind now, so that's the anterior leaflet of his tricuspid valve with the flail papillary muscle, and you can look down onto the valve leaflets and so on, and just get a sense for what's going on with that. I'm not going to go over in time, so I'm going to stop. Okay.
Girish, that tricuspid valve ruptured by a pumpkin must be in the Guinness Book of Records of bizarre events. Yeah. So, you know, as the previous speakers were thinking, this is a complex lesion, and I'm not going to go over the physiology again. That's been detailed. I'm going to talk about some other, maybe less important, but other aspects of Ebsteins. But I actually want to start with something much more important, because I noticed that a lot of you were not at the brewery last night. And I noticed that even those that took the tour weren't always listening. So the question, or what was put forward, and a lot of you are German, I know, is what 2 grains are used in German beer? There's only one right answer. This is a multi-choice question. Is it barley? Is it wheat? Is it wheat and barley? Is it wheat or barley? Or who cares? Just bring me my beer. Okay, which was my answer. Okay. It really was a very nice evening, Matthias. So you've heard about a lot of these abnormalities. There is abnormal RV geometry. There's abnormal right ventricular myocardium. There's tricuspid regurgitation. There's an ASD either way, and so you could call it loading or unloading. There are abnormalities of the left ventricle. The most recognized one is non-compaction of the left ventricle, which can cause dysfunction, and that's a cardiomyopathy essentially. And there are abnormal ventricular interactions, as I'll show you. These patients have arrhythmia which affect function. They can have conduction abnormalities and right bundle branch block, which might affect function and activation. They're cyanotic, which might affect myocardial function. And as Norman showed you one example, they may have congenitally corrected transposition, or Ebsteins may exist in that setting, and we talked about that yesterday. So there are many problems. And here's just one example. You can see of Ebstein's malformation and of left ventricular non-compaction. Now, I don't know what your experience is, Norman, but often when I see non-compaction in these ventricles, I don't, just by subjective looking, they're not dilated cardiomyopathy left ventricles like you see in irregular. So I don't know if there's data on the left ventricular dysfunction with non-compaction, but we know that that's well described.
I have
Yeah.
an explant from one of my patients.
Right.
With non-compaction with cardiomyopathy.
And with dilated cardiomyopathy? Yeah. Okay.
They frequently have restrictive physiology as well in their
Yeah, yeah.
They're not that dilated.
Yeah. I'll get to some of those abnormalities. But what also you see in this picture, and now it stopped playing because I messed around with it, but what you see if this plays is that this patient actually went in and out of arrhythmia during the echo. So it can be difficult to judge function, and this can also impact function. This patient had other issues. Here's the apical 3-chamber view, and you can see there's a VSD over here. And this patient also had coarctation or aortic arch narrowing with a gradient through there. So there are a lot of mixed problems in the same patient. And here's another patient with marked displacement of the septal leaflet. And here's the atrialized right ventricle. And this portion of the septum is very interesting in my opinion, and I'll come back to it. But you can see, if you think about this, you can see this paradoxical motion of that septum. Why should that be? The septum is between the left and right ventricles, but we kind of think of it as a left ventricular structure often. Why shouldn't it just contract and drag the ventricle with it? And obviously it's got to do with the volume and the loading and the pressures, but you can see how this has this very abnormal motion going into the left ventricle and in portions of the cardiac cycle compressing the left ventricle, and I'll come back to some work that's shown that. And here's just another view going down to the apex with the left ventricle showing that effect. And again, you see these abnormal trabeculations. I wouldn't call that non-compaction, but these LVs are trabeculated and look abnormal, and Girish has shown you 3D just to say that we can also do it. So, many different problems. It's difficult to have a unifying discussion on function, and there are many different procedures. This is from the Mayo Clinic data that are done. Both Norman and Abe focused on the critical aspects of Ebstein's. If you look at the other group who are not the critically ill neonates, the natural history, at least for the first 20 or 30 years, isn't bad, and there's often discussion when to intervene and so forth. But if it's not that bad, they live with this, the function may be not that bad. But what we do know in the long term, and I'm talking about these longer term survivors, is that function is an important determinant ultimately of outcome, both in terms of the size of the right ventricle and its function, but also look at the LV function preoperatively. That's also an important determinant of outcome. So if you have severely reduced RV and LV function, that is significant risk factors for poor outcomes. And then, as are associated conditions which are going to affect myocardial performance, if you have abnormal activation, coronary artery disease, etc., which might augment that dysfunction. In fact, some of the issues that were talked about in the fetus from Dov McElhaney were found to be risk factors for poor outcome. Here's the cardiothoracic ratio. And this is, of course, a mixture between the severity of the Ebsteins and possibly dysfunction. It's difficult to disconnect the two, one from another. And so that's why I said it's a complex matter. I can't just tell you that it's dysfunction. And, of course, severe TR, which is, again, is connected to the severity of the disease, but also overall the severity of cardiac performance. And that's going to predict postnatal death. And when I was preparing this lecture, I found this, which is very interesting, and this relates to what I think you said about restrictive physiology, perhaps in some patients. This is a paper from David Sellermeyer, and it's not a large series, but he was trying to figure out the morphology of the tricuspid valve, and there's detail on that. But what I brought this for was that he found fibrosis, quite severe fibrosis, or a quite large extent of fibrosis, both in the right and left ventricle of the patients. And in fact, this fibrosis was present in all layers. It was subendocardial, endocardial, it was mid-myocardial and subepicardial, which suggests that it's not just ischemia or a coronary perfusion, but abnormalities of the myocardium, and so that definitely will affect systolic and diastolic function. Ben Idem, who used the myocardial performance index that we talked about yesterday, which is the sum of the isovolemic contraction and relaxation times over ejection, you'll see that Ebsteins have quite abnormal myocardial performance indices, as do congenitally corrected transposition of the great artery. So this issue of abnormal hemodynamics and abnormal function perhaps formed the basis for this idea from the San Francisco group and Frank Hanley and Norman, etc., of unloading the right ventricle. This isn't a particularly prominent approach in Toronto currently. I don't know today. This is from 10 or so years ago. But the idea that you need to unload a small right ventricle and to assist in the performance is one that's being put forward. Now, in terms of LV function, so we've talked about non-compaction and abnormalities. This was also very interesting. There's not much data on strain, by the way. This is a paper from Lee Benson from 1987. He capped patients and also used echo to look at the interaction between the right and left ventricles, and also exercised these patients. And you can see there's a small number of patients. These were done in the cath lab, and you can see that these left ventricles are eccentric compared to controls, so they compressed. The eccentricity index is just the ratio of the two diameters here in the short axis, and they elevated or abnormal compared to controls, and obviously they have abnormal right ventricular areas. And this was associated with reduced ejection fraction at baseline, but overall the patients were able to increase their ejection fraction, largely due to a decrease in the end systolic volume index. So they did have overall in the small series functional reserve. But indeed, there are abnormalities of diastolic dysfunction, and even though these are within normal range, the deceleration time, which suggests relaxation abnormality here, was increased compared to controls and ASD patients. So again, it's complex, and there are a lot of abnormalities, difficult to differentiate the loading from the myocardial abnormalities, but it's both exist. I don't have information about a progressive dysfunction or serial dysfunction, and these different series, sample at different times, preoperatively or postoperatively, cross-sectional, but I don't have information on serial changes. I imagine that any operation would also affect that.
Left ventricle is smiling. Is that what I heard you say? Right. It's probably the only part that's happy. So Ebstein's malformation, obviously this is a very severe one. The patient did not survive. This is the patient's right atrium. And there's minimal lung tissue left due to that. So obviously the severity of Ebstein's anomaly is going to be really the decision maker in what needs to be done. And as Dr. Silverman pointed out, many of these patients, if they survive in the neonate period, do quite well. It's the ones that don't, that have pretty severe abnormalities in the neonate that have a difficult time. Cardiac MRI can help you again with the anatomy as well as the function of the left ventricle and the right ventricle to see if anything needs to be done. So here's an example of a teenager with Ebstein's anomaly, had not had any kind of surgical procedure done. You can see the tricuspid valve right here. The right ventricle is enlarged, quite a bit enlarged. You can see it's the apex forming part of the heart. Here's another example of that same patient. You can see where the Ebstein's abnormality is, here as well as right there. And it's generous, but not horribly so. At times it could be significantly worse. You can see here the amount of tricuspid regurgitation in this patient is quite a bit. By velocity encoded image, you can see the regurgitant fraction and calculate the regurgitant fraction of the tricuspid valve. And you can also see how enlarged the right side is compared to the left. So you can see at the beginning of the angiography, the right atrium being quite big as well as the right, and then you can see the nice small left ventricle. As several of the lecturers have spoken about, there's definitely left V non-compaction that can be present. And here you can see the tricuspid abnormality, the left ventricle, which here looks relatively okay up at the base of the heart. As you get further down in the heart, you can see the apex is quite abnormal with non-compaction of the LV as well right there. And as Dr. Friedberg mentioned, the LV is not dilated. There's non-compaction, but the ejection fraction at the moment seems to be okay. There's no dilation present there. You can see it by short axis as well. And you can notice that starting pretty early on, you're already seeing the trabeculation very much present. And we'll show more examples of this tomorrow with cardiomyopathy. So you saw this image in the beginning with the abnormal. This is the patient's chest. I showed you the long axis, and now you're seeing the abnormality here. So very impressive. Here's a couple more examples where the left ventricle is really almost becomes crescent shaped because the right atrium and the right ventricle are so dilated, making it difficult to fill. You can see it in several different abnormalities. Here's delayed enhancement, which isn't enhancing, and you can see the amount of tricuspid regurgitation here. You can also see Ebstein's anomaly with congenitally corrected transposition of the great arteries, where the systemic right ventricle has an abnormality of the tricuspid valve. You can see it right here, and again right here, causing it pretty severe abnormalities. Now, I wouldn't go as far as saying that you should operate on these patients with the same sort of criteria as patients with tetralogy of Fallot, but it does give you an idea of how enlarged the right ventricle is when you measure it by cardiac MRI and sort of look at the numbers and see when you have worsening right ventricular ejection fraction and worsening left ventricular ejection fraction. So as I mentioned in the beginning, the extent of the tricuspid regurgitation can be measured by cardiac MRI, and when it's associated with other complex cardiac malformations, it can help you very much with the anatomy. All right, I think we have maybe 2-3 minutes for questions. Any questions?
Dr. Rudolph wants to have a question. I also want anybody else who has a question to ask questions, and we'll try and get you a reliable answer from the panel. So, Abe, your question?
Well, my question is directed to all of you. And that is, because of the fact that the left ventricular myocardium is so often wrong, should we say that Ebstein's malformation is a myocardial disease rather than a primary valve disease?
I think it is. I think that it's fundamental. I mean, the whole ascent of the tricuspid valve by apoptosis is a process which looks for compaction of the right ventricle. And I think that the fact that you see non-compaction with this points that out. I mean, I think that that septal shift of the ventricular-ventricular interaction is not a great example of a myocardial. It's more of an interventricular thing. But clearly there are abnormalities, and I have an autopsy specimen of a mother that gave birth to a child with non-compaction who had a previous child with Ebsteins disease which died in the neonatal period, and another child who had no Ebsteins disease but who had severe non-compaction. And at one time the mother and the child both had defibrillators. Now the mother has a heart transplant for the progressive heart failure. And again, the interesting thing about this, which actually happens also in non-compaction, is that there's some endocardial fibroelastosis and restrictive physiology in non-compacted myocardium. So this, when you look at this ventricle on autopsy, it's not a large ventricle, but it's the kind of ventricle you see in restrictive cardiomyopathy, where you look at it and you say it's normal size. It's not, there's nothing grossly that gives you the understanding as to why it's left ventricle. It's not the left ventricle. Yeah. And then I think that, Mark, that point that you made about replacement fibrosis that Sellermeyer had pointed out is really quite fascinating, because you can see it all the time. And in the atrialized right ventricle, frequently that is undergone total replacement fibrosis. So, your chance.
Yes, I have a difficult question concerning the timing of intervention. I always have problems with patients Ebsteins with severe forms, morphologically speaking. Size tests, for example, they do well, and clinically they do well, and I have no idea when to intervene. Can you highlight a little bit on this?
Well, I'll give you my opinion.
Yes.
Based on my surgical colleagues, you know, it's always dangerous when you have a surgical colleague to tell you what to do. But they like to operate early, and the reason why they like to operate early is that when you damage a valve with regurgitation, after the repeated stress and trauma of the regurgitation on the valve itself becomes even more abnormal. And so the surgeon has suggested, and he sees a lot of these patients over the course of time, that if you have severe disease, you know, rather operate early because you'll get a better outcome from the surgery.
But do you agree?
The severe tricuspid regurgitation.
Do you agree?
Yeah.
You do?
Yeah.
So he says early.
Arrhythmias, well, yeah. Arrhythmias is another story. I mean, I think just as far as the arrhythmias is concerned, a number of our adult patients are getting the Mays procedure as part of the Ebsteins repair. So you do an atrial reduction, you do a Mays procedure, you know, the whole Mays business, put the atrium back together again, and then the point that I think Mark made about the reduction. One of the reasons why my surgeon has recommended a Glenn shunt as an unloading of the ventricle is not so much because you unload the ventricle, but because by doing that, you can actually do a better annuloplasty. You can make the valve smaller. When you make the valve orifice smaller, you allow the leaflets greater opportunity for apposition, and therefore less tricuspid regurgitation. So that's his philosophy for doing it. There's rarely a younger patient that we do surgery on that we don't do a bidirectional glennon at the same time.
I don't think Pedro has been doing that very much. The bidirectional glen. He's been.
Yeah. He's gone the cone route.
He's gone the
you
cone.
missed that.
Yeah, absolutely.
Yeah.
And so far the results have looked very good.
Yeah.
Really good.
They look good.
Yeah.
Some of them. We'll see. The main thing, we've also got a huge series of
Yeah.
cone procedures.
Yeah. I mean, I think it's early. You know, we don't have more than a few years, very few years of follow-up in this. So I think it's going to be another
one
5
thing
to
that
10
bothers
years
me,
before we really know.
the one thing that bothers me about the cone procedure is the sort of Brizard approach where you take a piece of pericardium and you detach the tricuspid septal leaflet and then you augment the septal leaflet on the annular side because that's the only way you can make the cone.
No, it isn't. I mean, they don't do much augmentation. They really use the leaflet tissue that's there.
But you know, in Ebsteins, the septal leaflet is often very vestigial.
And they don't use it much. There's a huge anterior leaflet, and there's usually an inferior leaflet,
Yeah.
and that's what they generally use and bring that together.
Yeah.
I don't think Pedro uses much prosthetic
Well, the
material.
pictures I've got from,
Yeah.
Doesn't use it at all.
No.
who doesn't?
No, he
Pedro.
presented that in Florida, and he doesn't use it actually at all. He
Yeah.
uses the
Well, I've got the silver stuff, and the silver certainly has, augments his leaflet.
Yeah.
Right.
I think that's a problem because I think that putting in prosthetic material, even if it's autologous
Right,
pericardium,
that's what I'm worried
is
about.
not a good idea because
Agreed.
it cicatrizes and shrinks and it
And it
becomes
looks
a
great when you start off, and then
Yeah.
later on it doesn't.
A year or two later, it doesn't look like that
Mhm.
anymore.
Other questions?
Do you treat duct intrauterine in your institution?
No, I have not done that. I have not used indomethacin. You know, there's a guy here in Germany, Thomas Cole, who's looked at increasing oxygen by giving oxygen to mothers, and he says that lowers right ventricular pressures. But I've not done either of those procedures in a fetus.
Wayne Tereski spoke about doing that.
Indomethacin and
Yeah.
oxygen?
And I don't know if indomethacin and oxygen, but
He
definitely
certainly reported
indomethacin.
indomethacin. I mentioned that
Right.
in his talk. Anyway, the thing about Ebstein's disease, I was just thinking about it in terms of coronary artery disease. If we saw as much Ebstein's malformation as we saw coronary disease, we'd all do a lot better with it. But it's unfortunately a rare disease, and it's very difficult to handle because each one of them is a very difficult problem. And I think Dr. Rudolph highlighted that I mean, you know, everybody sort of like provides new procedures and operations, including the ones in the, you can't do a cone procedure with some of the very small patients, and then, you know, you really are going down almost a single ventricle route in those patients.
But I think our approach to this has changed so much since I was in training, you know, where Dr. Feiler always told me to do as little as I possibly could with an Epstein.
He didn't only confine it to Ebstein's, right?
No, he didn't, but that was the archetype, I'll tell you. And that was the approach that was taken there for a long time. And now I think, you know, we're seeing people really operating on patients at a younger and younger age, even before they're terribly symptomatic. Sometimes there's really a lot of regurgitation. We'll see if that's the right approach. The other approach didn't seem to be quite right.
The ventricle gets beat up with a lot of regurgitation. You know that from the left side very, very clearly. And it happens on the right side as well. So
Our approach is still being out. The institutional approach, as far as I can tell, is not to operate until something's causing symptoms, arrhythmia, a change in function, decrease in exercise capacity. That's it.
I would say we follow more that style as well, where we wait. They were saying, you were asking that question, you were saying to do it earlier. We definitely wait until there's symptoms before we do surgery.
well, I think you should wait until there's symptoms, but a lot of Ebstein's have symptoms early.
That aren't so.
And the thing that's really the most depressing thing about Ebstein's malformation, when you look at the prognostic pointers as to what's important, and you come up with that the cardiothoracic ratio is a value. It's kind of a little bit of a dampening on all of the other investigations that we do about defining what is the best prognostic option for Ebstein's malformation. Okay. All right, we'll come back